The Hard Truth Season 8 with Akosua Konadu, proudly brought to you by EcoBank.
Good evening and welcome to The Hard Truth. Now, stakeholders in the health sector are questioning the role of the National Health Insurance Scheme in aiding the government to provide quality, efficient and effective health care delivery. And in fact, its sustainability has also come under sharp focus. This evening, we are discussing these issues with the new boss of NHIS, Nathaniel Otoo, and on the show Hard Truth. My name is Akosua Konadu, and this is The Hard Truth. Nathaniel, you're welcome to The Hard Truth.
I'm very well, thank you.
How are you enjoying your new position?
Well, it's not meant to be enjoyed, it's hard work.
So boss, they can call you Group C, CEO. How is it feeling like? Are you excited about it?
Well, you wake up the next day and feel that you have a completely different challenge. And
why is that?
I was not at the helm, now I am. Everything stops at my door. And so, yes, it is challenging, but I think we have the tenacity of purpose, the drive and the passion to do a good job for the people of this country.
Now, the health insurance providers, they brought a survey claiming that about 500 people have died during this period of strike, and that they blame it on indebtedness on your part, not paying about 12.5 million Ghana cedis to them, buying of the drugs to the health centers. I mean, what would you say about this?
It's really an interesting research. We are not being informed about it or being involved, but certainly it is to be expected that when healthcare providers, doctors withdraw services, especially in the public sector, there will be an impact for the population. And if there is an impact, it is not necessarily because of the NHIS.
No, not because of that, but they are claiming that some medicine, essential drugs to the health centers were not provided because you owe them $12.5 million.
We don't owe $12.5 million.
How much do you owe?
I'll put it this way.
Right.
On a monthly basis, we pay our healthcare providers 90.4 million. It could go up to 93 million every month. That is how much money the NHIS injects into Ghana's economy every month. This year, we anticipate to pay upwards of 1.2 billion Ghana cedi in health claims alone. It tells you the extent and the reach of the NHIS. Certainly, the NHIS has become the most important financing mechanism.
I get that because we did a survey. I went to some clinics myself, and when I spoke to the nurses and doctors, some few doctors, they said they didn't have some of the drugs there for the patients, hence some of them died. So if you had paid, the numbers might as well reduce.
It's an interesting extrapolation. But just to put it in context, if we do not pay our healthcare providers in time, it certainly has an effect on the operations.
So why don't you pay them on time?
Then you're coming to the question now. The NHIS currently has enrolled 10.5 million people as of the end of 2014. And these 10.5 million people went to the hospital or to health facilities 29 million times in 2014. We expect that it will be more in 2015. The NHIS has enrolled and is actually empaneled over 4,000 healthcare facilities. We provide a list of 525
So
medicines.
we get that. We get you are doing more. You're having a list of, we do get that. But we are in a period where people are dying. Doctors are on strike. That's the issue. Now I'm asking you, the insurance providers are saying you owe them money. Do you owe them money?
We do owe money.
How much do you owe them?
Because by the structuring of the NHIS, there will always be a gap between provision of services as well as payment.
Right.
By law, the providers have a month to submit their claims after service delivery. We have 2 months to pay. So if you have an indebtedness of 3 months, it is anticipated and expected. Anything upwards of 3 months becomes challenging for the healthcare provider.
6 months, they claim.
There can be, and there has been situations, I have seen it myself, where healthcare providers are owed, not sometimes even more than 6 months. But it is not deliberate. It is because there are challenges within the system. And if I'll just let you know, within a month of service provision, 41% of our healthcare providers, they submit their claims to us. Within 2 months of submission of rendering services, 75% submit their claims. By the third month, we go to 93%. From 3 months up until 8 months and upwards, you have something like 5% of providers who might not have submitted their claims. So the blame is on both sides. But in a large measure, we do owe providers across the board upwards of 2 months over and above the anticipated period for reimbursement.
Don't we have timelines? Providers, please submit your claims or whatever within a number of months.
That's what I referred to. The law says a month.
A month.
But we also do understand the challenges because, you see, the structures of our providers are varied. For example, when you go to the decentralized level and go to a CHIPS compound, they aggregate their claims and submit it upwards through the district health directorate. So there are challenges in the submission process. But some simply don't have the capacity. Majority of providers are actually up to the game and they do submit their claims.
So you owe those who haven't submitted, can I put it that way?
If you haven't submitted for 6 months, you'll be owed 6 months for sure. But those who have submitted within the 1-2 months that I talk about, we have not paid all of them. We actually owe 2 months over and above the 3 months that is actually anticipated.
So when should we expect payment? When should they expect payment?
Well, we don't do payment and stop. We do it almost every week. As we speak right now, for the month of February, we released funds to our district offices to pay around the country. We do have a few challenges with some providers, and they actually do complain. When they do, we take the issues on a case-by-case basis and deal with it. When we say that we've paid providers through February, it is looking at the large majority of those who have been paid, and that's actually not the exception, that's the rule. The exception is those who have not paid, and we go over and above, even the 2 months that we've not paid others.
Let's still on strike. Let's look at this. NHIS directed cardholders to go to the faith-based centers and the private, hospitals. Now, these people have huge numbers now, hence they are driving them away. They want money. Well, what are you doing about that?
We've had some of those. What we think is that when we have serious, genuine challenges, as you've seen, we have a channel for dealing with private healthcare providers generally, and it is their society. We do appreciate when they come up and tell us our challenges or what they think we are not doing right. And already we've had communication with their society and want to sit with them and see the way forward. At the end of the day, the NHIS has many parts. It is not one part, the other standing the part the other way. It is all of us together to resolve our problems.
No, but I get it. But if they are driving patients away to go home because they don't have money, I mean, isn't it diffusing the purpose of you driving them to, allowing or asking them to go there?
Well, that's a little unfortunate. But what I do know is that a large majority of private providers are actually accepting NHIS clients.
Yeah.
Oh yes, there might be exceptions. Yes, we do concede that. But where we see it, we'll engage the providers and speak to them.
So will there be sanctions? I mean, how are you going to punish them?
Well, let me put it this way. Certainly, our relationship with the providers is based on contract. But then also it is based in the context of an economy and what happens in an economy. As it is, the NHIS right from inception was anticipated to face funding challenges, after some time. And that has actually come to pass. Nobody has slept on their laurels on this. We have started working very hard to look at reform options for the NHIS. And the reform options are important to look at because the NHIS covers 95% of prevalent disease conditions in this country without co-payments.
95%?
Yes, 95%. Without co-payments.
Why do we go to the hospital and then, they just give us power and then the huge ones like prednisolone you have to go, to the pharmacy to buy.
I knew you were going to buy.
Of course I should ask you. If it's 95%,
well,
it doesn't add up.
Let me say this. In healthcare, the patient knows very little. Mostly the provider knows most of the information. That's why you go there, because that's the nature of healthcare. It's a professional specialist.
So I see my physician and he gave me a list of medicine to buy. Well, health insurance covers this, and then the rest go by.
Well, I will ask you the question: do you know what health insurance covers? I think that's where our shortcoming is, because we've not empowered the nation to be able to negotiate and to ask for what is rightfully theirs, and that is what we intend to do going forward. We are going to look at simple things such as having mobile queries and apps where you can, somebody says this is not on the list, you can query it. What we've not done is to put power in the hands of the citizenry to ask what is rightly.
So it means that as I sit here now, I take my phone and I know these are the services NHIS provides. So when I go to the hospital, I know my expectation.
That is where we're going to. That's where we're going
Fantastic,
to.
fantastic. We'll be right back. Stay on.
The Hard Truth Season 8 with Akosua Konadu, proudly brought to you by EcoBank.
At EcoBank, we see a great future, one that's full of opportunity for those who want to be the best. With over 1,000 branches of a single bank across 33 African countries. It's a future where trade can flourish without boundaries. The future is breathtaking, with enormous cross-border investments helping business and government build new infrastructure, while individuals achieve their ambitions right across Africa. The future is Pan-African, and EcoBank is the Pan-African bank.
Welcome back, and it's still The Hard Truth, and Nathaniel Otoo, new boss NHIA, is my guest. Now, capitation, sir. So capitation seeks to fast-track payment, at the health centers. They've been complaining of delays and all. And then capitation says, well, we are going to assign, card holders to specific, health centers, so that there won't be any confusion. Let's look at this. In a case where 20 people are assigned to Kolebu, and so the money is paid upfront or before, at the end of the year, or the beginning of the year, whatever it is. And then 20 people are assigned to Kolebu. Now 10 people go at the end of the year. The remaining 10, what happens to that money?
The money stays with the facility. What we
How
do,
are we sure?
Well, we are sure because it stays there. It's been paid to them. Now, what we do with capitation is this. You mentioned the fact that it fast-tracks payment is only one of the benefits, especially to the healthcare provider. But what we should look at is when we do capitation, it gets the healthcare provider to know their clients better, their patients better. Another benefit. There was a simple situation where a healthcare provider actually decided to distribute bed nets to the clients that come to his hospital. And what that is meant to do is to keep them out of the consulting room. So when you do capitation, there are a lot of incentives for providers to keep their populations healthy. But let me go to the specific that you asked. The rates that we pay to healthcare providers is based on averages. And even for non-capitation claims, it's based on averages. Averages that we do put together because of surveys that we do around the country. Now, when we've done the capitation tariffs, and that is where I need to probably educate a lot of the public on it.
Listening.
Our payment to the various facilities are different. Government facilities get a different capitation rate from private facilities and from faith-based facilities. And the reasons are that government facilities get their human resources paid for, and government generally pays for infrastructural development. What remains is the service. Okay, so capitation will cover the service costs as we anticipated. So if you take, for example, the payment per month per member, for the capitation, let's say for a private health provider, let's take it at 2 cedis 27 pesos per month. It is for the population that is registered and not for the healthcare episode, which means that if I pay 2 cedis 27 pesos, I'm not paying for your treatment of malaria, but I'm paying for an amount of money that you have to get to take care of a population for a year, but for convenience, we have broken it down into months. Because if I pay the entire amount at the beginning of the month, of the year, you are certainly going to have financial management challenges. So what we do, we split it down and we pay it every month. And let me just say that of the population that is registered to a healthcare provider, our analysis shows that 18% go to healthcare facilities. 82% do not go. Now, that risk has been factored into the capitation price, such that for each person that, for each 18% that goes to the healthcare facility, there are 82% that do not go. So they support the 18% that go to the healthcare facility.
No, but I get that bit, but vice versa, there's, hand in hand thing. I'm looking at in the case where they don't go at all, maybe 20 people are signed, 10 goes. What happens to the money is what I'm talking about.
The money is for the provider. It is for the provider, because there is risk in there for the provider. Even when we pay, based on DRGs or fee for service, there is risk.
But how do we account? How do we account and say, well, show forth? I mean, let's see the whoever came in. Let's see the remainder of the money. Is there a system?
No, we don't go to see the remainder of the money, because capitation is such that when the provider gets the money, it is theirs to manage. So we don't go that low. What is important is, what are the conditions people are presenting?
But what if the money is given to them earlier? They don't use it for the purpose, which is supposed to be used for.
Well, I probably would make it a little easier. When we do capitation, we have what we call performance indicators, or M&E indicators, monetary and evaluation indicators. One of the indicators we look at is the frequency of referral. So when a provider is taking the capitation money but is referring all the people out, it is perverse, and we have to deal with it. There is also the complaint of underserving of clients, such that the provider will collect money, but they don't give the clients what is their due. All those things are part of the monitoring framework for capitation, and we follow up on those.
Let's talk about your referrals. So I'm being referred to Kolebu. I've been assigned to 37. I've been referred to Kolebu. I mean, it's diffusing the whole purpose of capitation.
No, it doesn't.
I've been assigned to a specific. So what happens? Do I still take my card? What happens? Please explain.
Let me, through you, try to educate the public. The NHIS has 3 ways of paying providers. We are what we call DRGs, or diagnosis-related groupings. What that does is to take diseases that are very much alike and put them together in a group. So if you go to a hospital and you present with typhoid and present at the same time with malaria, what the old system of fee for service is saying is that the provider will bill for malaria, they will bill for typhoid. It is as if you go out of the consulting room and come back to be diagnosed for typhoid. But at the same time, you sit in front of the doctor, he's able to run tests and say you have malaria and you have typhoid. So what we do with DRG is just put all these together and pay one tariff. Now, when we come to capitation, capitation is based on a basket of services at the primary level. And what we've done is to package a set of services that can be rendered at the lowest healthcare facility in the country.
What's the primary level? Which level is
it? It is the CHIPS compound. So anything that can be done at the CHIPS level is what is in the capitation basket. Anything that cannot be done there is not in the capitation basket.
Explain better. If I'm referred to, a different hospital,
I thought you were going to take it easy. I will come to that. Now, within the structure of capitation, we also have fee for service, which is the reimbursement method for medicines. So when you go to the hospital and you're checked and looked at for under capitation, medicines are not part of it. It's only the service that the healthcare provider provides. Diagnosis, getting a folder and all those. Those are the only parts that are covered by capitation. Medicines are not covered. So I come now to your question.
No, so please go on.
Yes.
Hold on. Medicines are not covered.
No.
I pay for my own medicine.
No.
Okay. No. Yes, please explain further.
You use the existing NHIS system to get your medicines. Under DRGs, you either are given the medicines as part of the treatment or you refer to a pharmacy to buy medicines. That can be the same under capitation, because you can be referred out to buy, or the facility can give you the medicines. Now, when it comes to the question that you asked, capitation understands referral. So those services that cannot be rendered in the capitation basket are those that are referred. So if I went to a hospital for simple malaria, I'll be treated under capitation. If it were complicated malaria, I'll be referred out to a higher facility. That is how it works, and it is anticipated under capitation.
Okay. Now let's look at the, the pilots now, the Volta region and then the upper parts of the country. How is it doing?
We're doing very well. I'm happy to say that registration of people to PPPs. In the PPPs mean preferred providers in the 3 regions that you're talking about are going very smoothly. And as we speak, quite a big chunk of people, the population has been registered. What it is with capitation is that, like every insurance system, it runs on numbers. If I assign very few numbers to you, it is not very attractive.
But do card holders have a choice? Can I say I want to be assigned to this specific hospital?
Yes. What we've done, we have loaded all healthcare facilities in every district onto our system. And when you get there, you choose where you want to go. You have a chance to change after 6 months if you want to.
The Hard Truth Season 8 with Akosua Konadu. Proudly brought to you by EcoBank.
EcoBank, we see a great future, one that's full of opportunity for those who want to be the best. With over 1,000 branches of a single bank across 33 African countries, it's a future where trade can flourish without boundaries. The future is breathtaking, with enormous cross-border investments helping business and government build new infrastructure, while individuals achieve their ambitions right across Africa. The future is Pan-African, and EcoBank is the Pan-African bank.
One of the main challenges of the NHIS is the claims. And now we're here, which I think is fantastic that you've been able to, reclaim 110 million Ghana cedis. Let's look at this. I mean, I know that 20% of your activities are computerized, biometric and all. You have a system like that. But why don't you, NHIS and your stakeholder, the health centers, have a computerized system, 100% computerized system to fast track, the checking? Because these guys go to the hospitals, take huge months or number of months just looking through documents and books just to correct things. I mean, how are you going to fix it?
Well, I mean, part of it is our state of development as a country. But you would agree with me that since the NHIS came, we have actually catalyzed IT in the health system. The NHIS, with all our challenges, are able to issue your ID card when everything is working within 15 minutes. We have surmounted the challenges in card issuance. Now, the next step we are going to take is to actually computerize a lot of our operations and let one, system talk to the other. Now, but that is only within. Without, let us look at the investments that are made in IT. We have, close to 2,000 CHIPS compounds, I believe, and these are in very remote areas. How do you serve them with IT? We have to look at other alternatives, such as mobile health or use of mobile telephony, to reach them.
I'm talking about these health centers or wherever they go to check. People bring false claims. You want to check to see if it tallies or not. So they go to, say, Rage Hospital. They check, okay, this is true, this is not, and no. And it's like manual. How do we fast track is what I'm asking.
Well, you'd have seen what we're already doing. We've started an e-claim system. We have about 52 facilities already enrolled. And these are 52 big ticket facilities. The facilities that submit our big claims, they are all on e-claims. About 10% of the payments that we make go to these facilities. By the end of next year, we anticipate about 160. We select based on the volume of claims and also the risk of making errors in these volumes of claims. But then there is the other side. The health facility has to be ready. You have health facilities that are not IT ready. They are not networked in their operations. The NHIS cannot resource health facilities to get computerized.
Why is that?
How can we
delay the mode of payment,
yes,
because you have to take months.
But I cannot take tax money and give it to a private provider to set up an IT system. What I can do is to enable a system that allows that person to interface with the national health insurance system. And we're already doing that. When it comes to e-claims, the benefit in there is that the providers get paid quicker. Or at least that's our plan. Typically, an e-claims...
not quick enough anyway.
Well, an e-claims provider is paid typically 1 month ahead of other providers. Firstly, because an e-claim takes a second to register in our system, okay? The e-claims face the similar challenges of delays in reimbursements, which are not because the system cannot verify, but it's because of what we've said are the payment challenges that we've had over the period. Now, coming back to it again, we would wish that everything were computerized.
So do you talk to them? Do you
yes,
do urge them to?
Yes, we do urge at every time that we can. But remember that it takes, investment. And that investment, we encourage the private sector to make it, as well as government hospitals. A lot of them have done it. Komfuanochi Teaching Hospital, Kolebu, Tamale Teaching Hospital, as some other regional hospitals, and some private providers have actually invested in it. It's good. It's a good investment. Not only that is it sensible for the NHIS, it is sensible for the providers themselves, because when you computerize, you are able to optimize data capture, analysis, and so on.
True.
So the benefits are all over.
So, I mean, it's not okay to just recoup 100 million Ghana cedis and be excited. Aren't you going to punish those who ballooned the budgets? And what are you going to do?
Well, we have, when we do clinical audits, and I think that's what you're talking about, together with claims vetting, you find things that are errors. If somebody writes paracetamol, let me just use that example, and puts a price of 100 cedis, there is obviously an error. And so when we adjudicate, we have to take those ones out, okay? Because ordinarily they would have been paid for if we didn't vet. And so all those things we do to make sure the prices are right, the diagnosis is right. If you came in with a disease or a condition and some other prescriptions were given which don't match it, we don't pay. Now, on top of that, we go to the facilities after the fact to inspect patient folders, to check whether they were billed right, whether the procedures that were used were right, and so on. It is the collection of all these that I believe made the headlines that we have saved 100 and something million. It is, I believe, part of it is due to hard work and innovation, which we started typically, I think, in 2010 with clinical audits, but also with the claims vetting centers, where we have a lot more experienced people than we had in the past.
Nathaniel, you are talking like it's fine. I mean, put in 100 Ghana cedi, we just come and bring our audit and then we reduce to 10 Ghana cedi, it's okay. What are you doing? I mean, someone will go somewhere. What would you do to them so it doesn't repeat again? If it's 10 cedis, it's 10 cedis.
If it's 10 cedis, it might not be 10 cedis, because I won't control the person writing it out there.
So he writes 100 cedis.
Well, let me say, if a claim is coming,
yes,
we don't fill it. Somebody else does. And if they put 100 cedis, I have no way of holding their hand to write the right amount. So, some come with errors. We correct the errors and we tell the providers what it is. But when it comes to pure fraud, we do take steps. I'm sure you've seen in the newspapers, you've heard in the media some of the steps we've taken.
Please tell us, what steps have you taken?
We have arrested, we made a complaint to the police. They have arrested and investigating a healthcare provider in the Western region. There was another one in the Ashanti region that came in the papers 3-4 months ago. We have other situations. We have cases being prosecuted in the Sekendi High Court, in other places. Health fraud is a very difficult thing that attends not only insurance but health all over the world. And we can only try to come up to the level where we can detect it early and prevent it.
The Hard Truth Season 8 with Akosua Konadu, proudly brought to you by EcoBank.